So the topic of discussion that we are going to deal with is membrano proliferative glomerulonephritis. So membrano proliferative glomerulonephritis. So under this topic we'll be going through all these things, the diagrams from Robbins, the content from our first aid, and these note. And okay, now this is what we will be going through. So now before beginning, I would like to add one important note right here, and that is okay, this our membrano proliferative glomerulonephritis, it was previously called, or another name for it is our mesengiocapillary glomerulonephritis. What I'm saying is mesengiocapillary glomerulonephritis. Now let's just go toward the words, right? Let's go toward the word. Here you can see mesengiocapillary glomerulonephritis. Okay, this mesengiocapillary glomerulonephritis, or our this membrano proliferative glomerulonephritis, what is this? It is immune mediated injury. But I'm saying it is immune mediated injury. Okay, it is immune mediated injury, and it is not separately itself a disease. It is just an immune mediated injury. Now here what will happen, that there will be proliferation of mesangial cells. There will be proliferation of mesangial cells along with its matrix, right? Along with its matrix and our endocapillary, right? There will be endocapillary proliferation also. Now one of the distinguishing feature that we will find in the case of our this membrano proliferative glomerulonephritis is that we will find lobular appearance in the case of our light microscope. What we'll find lobular appearance. As you can see, these are our lobular appearance. Okay, membrano proliferative glomerulonephritis. As you can see, membrano proliferative glomerulonephritis showing mesangial cell proliferation, right? Mesangial cell proliferation, increased mesangial matrix, as we talked about that thing. Also basement membrane, right? Basement membrane thickening with segmental splitting, accentuation of lobular architecture. As you can see, lobular architecture, swelling of cells lining peripheral capillaries and influx of leukocytes, endocapillary proliferation. So this is what this is about. This is about the lobular appearance, right? Lobular appearance of our membrano proliferative glomerulonephritis. Okay, now moving further, what I would like to mention here is, okay, this mesengiocapillary glomerulonephritis, or our this membrano proliferative glomerulonephritis, it is a mixed picture. What we are talking about? We're saying that it is a mixed picture. That means here we will find nephrotic syndrome, right, along with nephritic syndrome. That means we'll find both characteristics. Okay, now since we're saying that we'll find both characteristics right here, that means we'll find what? We will find proteinuria also, right? Proteinuria also, and hematuria also in same case, right? There will be also, we're talking about the clinical condition. What we'll find hypertension also. We'll find malaise also. Yes, these are the clinical manifestation that we'll find. Now after this, the thing that I would like to take you toward is, I would like to talk about its type, right? It is of different type. Okay, now there are two classification. One is our traditional classification, right? And in traditional classification, okay, what was going on there is, there were three types. There were how many types? There were three types. Okay, the type 1, type 2, type first, type second, and type third. Now this traditional classification, it was based on the finding of electron microscope in kidney biopsy, right? On the basis of location of immune complexes where they are present in kidney. So type 1, what was this type 1? There was the deposition of immune complex in subendothelial region, where there was the deposition of immune complexes subendothelium, right? And similarly, talking about type 2, there were the deposition in in our basement membrane. That means dense deposit in basement membrane. And talking about type 3, what was type 3? There were deposition where? In subepithelial region. Where? In subepithelial as well as endothelial. So traditionally this was the classification which was just being followed traditionally, but nowadays what is going on is nowadays there is separate classification, right? So okay, now talking about the current classification, right? What we are doing dealing about with current classification. Talking about current classification, what we'll do is initially, okay, now before classifying, let me mention that initially what we'll do, we'll look light microscope, right? Now in this light microscope, what we'll find lobular appearance, as we have already discussed earlier, appearance, right? Now if there is lobular appearance, then we'll just say that it is the case of what? It is the case of our membranoproliferative glomerulonephritis. Now after knowing about our lobular appearance, what we'll do is we'll do immunofluorescence, right? We'll just diagnosis through immunofluorescence. Now while doing immunofluorescence, what we'll see is, right, based on it, what we'll do is we'll classify what is this, our membranoproliferative glomerulonephritis, Mpgn, right, into two class, right? Class 1 and class 2. Now what are these class 1? The class 1 are the one which are having what? Only C3, right? Now these are having only C3. Now this the first class is the class which are having the C3, right? The one is okay, let's not mention type 1 and type 2. Let's say that there is one class that is just having the deposition of C3 complement 3, right? And another class is there that is having the deposition of both C3 and immunoglobulin. Okay, and these things we knew it with the help of immunofluorescence. Now another thing that we will do is, okay, what we'll do is we will just look toward what? Electron microscope, right? Now in electron microscope, what we'll do is we'll find the presence of subendothelial complexes. Okay, now let me classify it. As I have said that how many classes will be there according to immunofluorescence? There will be two classes. What are the two classes? The first one is what? The first one is there will be what? There will be the presence of immunoglobulin also, and there will be the presence of complement C3 also, right? Now okay, now what will happen in this case is, okay, now the next one is the one in which there will be what? There will be no immunoglobulin deposition, but there will be complement C3 deposition. Okay, now talking about this one, right? Talking about this one in which there is the presence of immunoglobulin also, what will happen here is there will be the activation of both classical, right? Okay, what will happen here is there will be the activation of classical as well as what? As well as alternate, right, complement pathway. Now because of this activation of all classical as well as complement pathway, what will happen? There will be what? There will be deposition. Of what? C4, C3, C1Q, everything, right? There will be deposition of these C4, C3, CQ, right? And because of excessive deposition of these complements, what will happen is that there will be hypocomplementemia, right? Hypocomplementemia, right? Hypocomplementemia. That means okay, we understood about these things. But here since there is only the presence of what? Complement 3, right? What will happen here is this is overall we call it as C3 glomerulopathy. Now here in this glomerulopathy, right, C3 glomerulopathy, what we have is we have further more divisions. Now what are the divisions? Right here, right, the thing that we need to discuss right here is there will be what? There will be C3 glomerulonephropathy, right? Now another is our dense deposit disease. What is this? This is dense, and this dense deposit is the one that we will be discussing in detail. Dense deposit disease. It is also called what? 3D, dense deposit disease. Now right, and another is our CFHR, right? Okay, now here, now what we'll do is we'll just look in detail about what? about these things. So we said that we are classifying what the current classification we are doing. How we are doing in the presence and absence of immunoglobulin. If there is the presence of immunoglobulin, we are keeping it right here, and if there is the absence, then we are calling it C3 glomerulopathy, right? And under this C3 glomerulopathy, we are just we are just dividing it further into these 3 types. Now what will happen in the case of our this C3GN, right? Complement 3 glomerulonephropathy. Okay, now here it is simple, right? This C3GN is just, it is simple. The thing that we will be dealing here is, in this C3GN, what will happen is there will be deposition of electron dense material, right? Electron dense material will be deposited. It is lighter and it is amorphous. It is lighter and amorphous in nature, right? And it is especially seen in the case of elderly people. And here what will happen, there will be excessive hematuria, then proteinuria. So this is what we need to know about C3, right, GN. Now talking in detail about what about dense deposit disease. Now talking about dense deposit disease, what we will do is there will be okay, now there will be what in the case of our this dense deposit disease, what we are saying is there will be alternate pathway dysregulation. That means alternate pathway. Okay, in the case of this type 1, what we are saying that there will be activation of classical and alternate complement pathway, but here we are saying that there will be alternate there will be dysregulation of alternate pathway only. That means we're talking about alternate pathway only, alternate pathway of complement activation. Now because of these things, what will happen, right? Now because of this thing, what will happen is there will be involvement of C3 protein only, not all these three, our C4, C3, CIQ. There will be C3 involvement only here. And what we will find, one important find is that in immunofluorescence, what we will find, there will be C3 involvement in mesangium on circular ring, right? The C3 will be appeared in circular ring. Okay, now one important thing that we need to know here is there is the presence of autoantibody, right? Autoantibody. Now the name of this autoantibody is our C3NEF. Now what is this C3NEF? It is C3 nephritic factor, right? Now what is this C3 nephritic factor? It will do is, okay, before getting into this thing, what we have is, we know that there is C3 convertase, right? Alternate C3 convertase, let's say alternate C3 convertase. What this C3 converter does is, this C3 convertase will convert this C3 into C3b, right? Now what this this C3NEF will do is, this will overactivate our this alternate C3 convertase. Now as there will be the overactivation of our this alternate C3 convertase, there will be the high increase in C3b, but there will be reduction in C3. Okay, and as there will be the reduction in C3, we call it persistent hypocomplementemia, right? Persistent hypocomplementemia, right? emia. Okay, now in this case, another important thing that we need to know here is, there will be in clinical manifestation, there will be excessive proteinuria rather than hematuria. Okay, in the case of here we are discussing that there will be excessive hematuria than proteinuria, but here we are talking that there will be excessive proteinuria than hematuria. Here there will be excessive proteinuria than hematuria. So here, now another thing that we need to know here is, okay, in 10 years of patient, what will happen in 10 years of patient, there this condition will give rise to what? This condition will give rise to chronic kidney disease. Now this chronic kidney disease, now let us let us just recapitulate whatever we have studied right now. Okay, we talked about what? We talked about lobular appearance, right? We said that we talked about the 2 types right here. The 2 types are types 1 and type 2 here. Let me just make you clear that this type 1 is the one here, right? This is the one that we were discussing right here, the one which was having immunoglobulin with it. So this is the type 1 that we are discussing. Okay, here what we said that there will be what, there will be complement activation by both classical and alternate pathway, and there will be what, there will be deposition of C1, C3 and IQ, and because of which there will be reduction in this complement, our complement, and that we were calling what, hypocomplete and this will be deposited in subendothelial region. Now talking about type 2, yes, we talked about different types, right? We talked about what, this, right? And here, and this is especially what, this is especially this is especially concerned with our DDD, right, dense deposit disease. So here what is going on is there will be what, this here C3 nephritic factor, right? This was what, this was our what was this, this was our what, autoantibody, right? This C3NEF, this was our autoantibody. Now this autoantibody was, what was doing, it was it was overly activating our C3 convertase, right? C3 convertase, and because of overactivity of C3 convertase there will be reduction in C3, right? Because everything will be converted into our what, C3b, and because of less complement C3, what we were calling persistent hypocomplimentemia, right? And this was what, the dense deposit disease. Okay, now another thing that we need to discuss right here is, okay, as I was mentioning, right, there will be the condition of chronic kidney disease also. Now how we are going to treat this patient? So in order to treat this patient, what we can do is we can simply do kidney transplant, right? Transplantation. But when we do kidney transplantation, what will happen is that patient are still, when there will be the new kidney, the patient will be having autoantibody, right? Autoantibody, and this autoantibody, what it will do is it will again go and attack to the new kidney, and if there will be attacking to new kidney again, so there will be the condition of recurrence. So these have high recurrence value, high recurrence, right? There is high recurrence condition right here. Okay, now talking about another thing that we need to know here is about this diagram. So in this diagram, what we need to know here is, this is what it is, electron microscope, right? It is electron, it is the diagram from, it is the field of electron microscope. What is going on here is, okay, there will be what, extremely dense material, deposition of extremely dense material, right? There will be the deposition of extremely dense material, as you can see right here, right? And it is going to be deposited, what, it is going to be deposited where, intramembranously, right? It is going to be deposited intramembranously, and here as you can see the dense, and it will give what, ribbon like pattern. As you can see, it is giving what, ribbon like pattern. So this is also one of the most important point that we need to know. Okay, now another thing that we need to know here is, okay, let me just, yes, we talked about this thing, right? We talked about C3, it was being converted into its active form, right? Now yes, here C3 was being converted to its active form, right? And here we were having C3 convertase. What was this C3NEF, right? Nephritic factor doing C3, nephritic factor was just overactivating this C3 convertase, right? And because of which there will be excessive production of C3b, but less there will be reduction in number of C3. That is why we were telling it what, we were telling hypocomplimentemia, right? So this was about this diagram. Okay, now another thing that we need to know here is, yes, as I was mentioning as earlier I was mentioning about traditional classification, right? And traditional classification was based on the deposition of immune complex in the different region of our kidney biopsy, right? Okay, now here one important thing that I would like to mention here is, because of okay, let me just write, okay, this is our endothelium, right? This is our endothelium, right? And this is our basement membrane, right? Now here, if you just see our this type 2, right, there was the deposition immune complex deposition in our basement membrane right here. Okay, let's see. Okay, because of this deposition in our basement membrane, right, this basement membrane now will split into what, two part. That means there will be what? Split like appearance, right? There will be what? There will be split like appearance. Now this split like appearance, okay, right? The single basement membrane, there was single basement membrane, but because of deposition of what? Immune complex right here, right? Now these our single basement membrane will just appear as two, right? Right? Split appearance. Okay, now because of this split appearance, what will happen is there will be there will be our, okay, it's not okay, there will be what? There will be tram track appearance. There will be what? There will be tram track appearance. Now why this will happen is because of duplication of glomerular basement membrane. But why that duplication took place? That duplication took place because, okay, this is our what? This is our basement membrane. Now here what is going on? There is deposition, right? Deposition. Now this deposition is causing what? To what? Partition, right? Partitions, and these two partitions what we are calling as duplication of glomerular basement membrane. Now it is best seen in our silver stain. It is best seen in our silver stain. I forgot to mention diagram right here, okay, and this is one thing. Another thing that we need to know, okay, as you can see, this is our mesangial cell, right? And here you can see what? These are our endothelium, right? Now as you can see, what you can see right here, this is our basement membrane, but here in this basement membrane we can see there is deposition, right? Deposition, and this deposition is causing what? Splitting of basement membrane, right? This splitting of basement membrane, and this will cause what? This will cause tram track appearance. This is so important. It is called what? Tram track appearance. So this is one of the important thing that we need to know. Okay, now okay, what is remaining right here? Yes, we talked about tram track appearance, right? It is same thing right here, tram track appearance. Okay, now here another thing that I would like to mention here is while treating these patients, right, these patients will not respond to steroids, right? They cannot be treated through steroids. So this is one important thing that we need to keep in our mind. Okay, and now let's move toward what? Let's move toward our the content of first aid. Now here membrano proliferative glomerulonephritis. Here the thing that we need to keep in our mind is what? Is a nephritic syndrome that often co-present with nephrotic syndrome. So both are here, so it is mixed. We call it as what? Mixed picture, right? There were both nephritic and nephrotic also. But here the what it is saying is what we mentioned earlier is what? The nephrotic syndrome is the predominant one, right, than nephritic syndrome. Okay, now here and then what is mentioned right here is it is mentioning about its type 1 and type 2. Now here type 1, it is okay, this division, it is what? It is current classification. We are not going through our world traditional classification. Talking about type 1, it may be secondary to hepatitis B or hepatitis C infection, and many time it is idiopathic also, right? Okay, now what will happen here is there will be immune complex deposition in subendothelium, right, and it will cause granular appearance in immunofluorescence. Talking about type 2, here it is mainly talking about triple D, right? Now here it is associated with C3 nephritic factor. Okay, what is this C3 nephritic factor? What it is? It is autoantibody. If you remember, it is autoantibody that is causing excessive activation of what? Our C3 convertase. As you can see, C3 nephritic factor, right? IgG autoantibody that stabilizes C3 convertase, right? Persistent complement activation. Yes, same thing. It is causing what? Reduction in C3 level. Yes, we talked about this thing. And what is going on here is there will be intramembranous deposit. Yes, we talked about this intramembranous deposit, because of which intramembranous basement membrane, because of which there will be glomerular basement membrane splitting, and that will appear as tram track appearance. And this is what? This is our tram track appearance, right? And it is mainly obtained by silver stain. So this was about what? This was about membrano proliferative glomerulonephritis, and this much for this topic. Meet you at the next lecture.